Welcome, everybody. My name is Enrico Roveda, Global Marketing Director, and together with the entire Alvimedica management, I'm very pleased to have you joining this webinar titled Cre8 EVO, the sweetest thing for PCI in diabetes mellitus patients. We hope you will enjoy it a lot. So without any further delay, I leave the stage to Professor Gennaro Sardella, who will chair the session. See you soon.
Thank you, Enrico. It's my great privilege to open this session. I will present my two dear colleagues and friends, Professor Daniel Aradi from Hungary and Dr. Rafael Romaguera from Spain. The webinar is titled Cre8 EVO, the sweetest thing for PCI in diabetic patients. This is my disclosure. The main webinar objects are focused on diabetic patients and this need for a more appropriate invasive treatment, show the latest available evidence on diabetic invasive treatment, to discuss the strength of new available clinical evidence to support the concept of a new tool in the fight against diabetes, and finally to discuss if this new tool could reduce the gap between PCI and CABG. I invite all the audience to raise the hand for the chat, to make questions. It would be a very interactive webinar, and I give the word to Daniel Aradi for his first speech. Please, Daniel.
Thank you, Professor Sardella. Okay, so thank you for the invitation. I'm really happy to be today with you, and I would like to give a short introduction about the PCI efficacy in diabetic patients and what is really the problem in diabetes, what are the challenges. These are my disclosures. So I think we are now living in a pandemic era with an infectious disease, but we need to know that a non-infectious disease is really important, which is diabetes, which is a worldwide affected disease. And this is not only affecting the Western world, such as North America. Diabetes is very highly prevalent in Southeast of Asia, but also in Latin America, Central Europe. So diabetes burden is really a global worldwide issue. If you look at the projections about how the diabetic patient number will change in the upcoming years, we can see that the number of diabetic patients will increase dramatically in the upcoming years. So diabetes is really becoming a more and more problematic disease in the upcoming years. And if you also observe the death toll, the mortality dedicated to diabetes, it will also increase largely. So it will be really a big healthcare issue, and we need to do something to treat these patients better. And although in the past, let's say, decades, we achieved really important and dramatic improvements in mortality of non-diabetic patients, nowadays we can see that the mortality of diabetes is not improving as it's in non-diabetic patients. So it seems that the survival rates are leveling off, and there is a huge gap between mortality in diabetic and non-diabetic patients. And this gap is also true in cardiovascular mortality and coronary heart disease mortality. So we need to try and find solutions, treatments, interventions to reduce this treatment gap between diabetic and non-diabetic patients. So I will now show you a very typical story of a diabetic patient. This is a female patient, 75 years of age, quite obese, BMI 32. She is having diabetes for 25 years. She had known hypertension and hyperlipidemia, no prior event. And she is now treated with regular medications, antiplatelet agents, ACE inhibitors, and anti-diabetic drugs, statins. Despite these medications, She's presenting with a non-STEMI currently. And according to the urgent angio, we reveal a significant left main disease, and we reveal critical stenosis in the right coronary artery. So in this non-STEMI, we try to treat the culprit lesions and start with the right coronary artery, a successful PCI with 2 DES in the right coronary artery, and then following with the interventional treatment of the left main with good angiographic result. So I can conclude that in the cath lab, we almost did what we could to save these patients, implanted 3 DES with good angiographic results. We also try to do our best to improve outcomes regarding medical therapy, because we know that in diabetic patients, we need to focus on many issues to control residual risk. And I would like to highlight 3 aspects of drug therapy that have been improved in the prior years. Residual cholesterol risk, residual thrombotic risk, and residual diabetic risk. So regarding residual cholesterol risk, I think it's very important to highlight that type 2 diabetic patients with high or very high cardiovascular risk need to have completely optimized LDL cholesterol level, which means that an LDL-C below 1.4 or 55 milligram per deciliter, and at least a 50% reduction prior to baseline. And usually this is not achieved by a statin monotherapy, so we give another drug, let's say ezetimibe, to improve LDL cholesterol. And as you see in this study, diabetic patients benefited more from optimized anti-lipid lowering therapy, ezetimibe therapy, than non-diabetic patients. And there is another group of new and very potent lipid lowering drugs called PCSK9 inhibitors. And according to the guidelines, if we are not achieving the goals with oral therapy, PCSK9 inhibitors should be also used. So after lipid lowering, I would like to focus on thrombotic risk. And we have many studies confirming that diabetic patients have a higher risk for thrombotic events. And especially those who are after PCI, they need more potent antiplatelet therapies. So that's the reason why we are using more potent antiplatelet drugs such as ticagrelor and Procedural more frequently in diabetic patients. And also we need to consider that there have been large improvements in anti-diabetic drug treatment in diabetes. So now we have drugs that are not only improving blood sugar levels, they are improving outcomes, especially 2 classes of drugs, SGLT2 inhibitors and GLP-1 receptor agonists. They were really effective in reducing not only blood glucose levels, but also key endpoints, such as in this meta-analysis, where GLP-1 receptor agonist reduces MACE, myocardial infarction, cardiovascular mortality, and all-cause mortality. So we have now drugs that really improve outcomes. So in our patient, after a good cath lab result, we try to do our best. We give potent antiplatelet agents, we give an additional strong lipid-lowering therapy, and we introduced an outcome-modifying anti-diabetic treatment. And we hope the best. And we think that we are done with this patient. But reality is not like this. Although we think that the patient is perfectly treated, she comes back 6 months later with recurrent angina. So we go back to the cath lab because she has a left main stent, and we would like to know what's going on. And unfortunately, we see that there is a significant instant restenosis in the left main stent without big problem in the right coronary artery. So we think that this is a rare thing, but this is not. In fact, if we go to current evidence, whatever stent technology have been used previously, it could be sirolimus eluting, everolimus eluting, or zotarolimus eluting stent. All of these DES technology failed to close the gap between diabetic and non-diabetic patients. So in all these trials, like in the BioResort randomized controlled trial at 5 years, diabetic patient had 50 to 70% higher risk of target lesion or target vessel failure. So still with this DES technology, target vessel failure is prevalent, and it's a lot more frequent in diabetic than in non-diabetic patients. So to summary, I wanted to give you some introduction that the global burden on diabetes is really an important healthcare issue, and the rate of diabetes will increase rapidly in the upcoming years. Mortality in diabetes did not improve as much as in non-diabetic patients, and there is a huge gap between diabetic and non-diabetic patients in outcomes. And we need to acknowledge there was a big improvement in drug therapy. So now we have outcome modifying drugs that reduce cardiac events, including new antiplatelets, potent lipid lowering, and disease modifying anti-diabetics. But still, before this trial that you were here in the upcoming moments, there were no big improvement in stent technology for diabetes, because post-PCI results were significantly worse in diabetic patients with all prior DES devices compared to non-diabetic patients. And these failures were mostly related to target vessel failure by increased risk of MI and instant restenosis. So we need to do something in the cath lab, not only in drug therapy, to improve outcomes. So thank you for my opportunity for this introduction. I would like to give the words to Rafa.
Thank you, Daniel. This is a very nice presentation. So as Daniel pointed out, with the current DES technology, patients that undergo PCI have twofold risk of adverse event in the target vessel failure. And patients with diabetes mellitus and multivessel disease have an increased mortality compared to surgical revascularization. I think that one of the causes of this situation, one of the most important, as you can see in this slide, is that patients with diabetes has an resistance to the antiproliferative drug. As you can see here in the lower curve, patients without diabetes mellitus with increasing tissue drug concentration of rapamycin, you can achieve an only 20% of proliferation of the cells. By contrast, with the lowest dose of sirolimus, you don't have any anti-proliferative effect in patients with diabetes, and you need 10 times the same concentration to achieve similar levels of anti-proliferative drug. The problem is that for DES based on polymers, the drug diffusion is achieved by simple diffusion. So you have very high tissue drug concentrations that may be even toxic when you are very close to the stent, and the drug concentration in the tissue decreases in points that are far from the stent. Indeed, you might have gaps without drug between the struts. For this reason, some companies, they put the struts together to avoid these gaps. But as you might know, it may also be problematic to have a very high metal to artery ratio. So in this case, with polymer-based DES, you may have gaps without drug in patients that indeed need higher tissue drug concentration. And then is also another problem. Patients with diabetes has diffuse disease. So they have plaque, calcium, so the drug diffusion is not homogeneous. By contrast, the Cre8 stent have different features. The most important feature for me is that it has an abluminal technology reservoir, that it means that it has laser duct wells only in the stent abluminal surface. And in these wells, they put the drug together with a carrier. The whole stent is covered by a bioinducer surface. And as you can see in this slide, on the right side, when you use a polymer-based DES, the polymer acts as a net. So you have the holes in a single size. You might put there the drug to be released by simple diffusion. You have the holes of a size. So if you put two drugs, what will happen is that the smallest drug will be released very fast and the biggest drug will never be released. For this reason, they can only put a single drug in the stents. As you can see below here, this is the drug concentration. You can have peaks of concentration when you are very close to the strut and valleys without any drug when you are far from the strut. By contrast, in the Cre8 stent, the abdominal reservoir, here you can add the drug with a carrier that in this case is an amphiphilic carrier, meaning that it has a lipophilic and hydrophilic bonds. This carrier is namely a fatty acid, which allows a high diffusion to the tissue and also very homogeneous diffusion. So you may have high tissue drug concentration also between the struts. This is also especially important in patients with diabetes because they cannot have a glycemic metabolism, so they have hyperexpression for fatty acids in order to achieve the energy from fatty acids. So with this formulation, which means the drug together with the carrier, which is a lipophilic acid, you have homogeneous distribution and high intake of the drug and the carrier. We test this hypothesis that, as I said, it was only a hypothesis in 2012. And first, we designed the reservoir trial, which was a small mechanistic randomized trial in which we compare patients with diabetes mellitus that were randomized in 4 centers to either Cre8 or Science stent. We had a angio and OCT follow-up at 9 months, and we found that the lead loss was numerically lower than in Science. But the most important finding is that the standard deviation was very, very thin, meaning that all the numbers of the lead loss were very close to this 0.14. By contrast, with the Science, we had a large standard deviation, meaning that we had some negative remodelings and some occlusive restenosis, and for this reason, the standard deviation was larger, meaning that the lead loss was a very, very diffuse, large distribution. We also found that the MLD at follow-up, the minimal lumen diameter, was larger for the Cre8, and this has an prognostic impact. And regarding the OCT parameters, both stents had similar rates of cover struts, and the neointimal hyperplasia volume, it means that hyperplasia causing the obstruction, was non-inferior for Cre8 and was even superior for patients with a worse metabolic control. With these nice results, we did also a pool analysis with our patients from Reservoir, the patients with diabetes mellitus from Recre8, and the patients with diabetes mellitus from the next trial. And we saw a very important trend to reduce TLR up to 3 years for patients treated with Cre8. So with this important background, we decided that we need more important clinical data because all of these trials were pool analysis, or the Reservoir was a mechanistic trial, and we needed to know if there was a significant reduction of events for the Cre8 stent, meaning that if it was good exactly for the patient. So we designed the SUGAR trial, which was an investigator-initiated trial, randomized control trial, 1 versus 1, conducted in 23 centers in Spain. The randomization was performed in a wave-based system. Only the event committee was masked because the stent is different to the naked eye, so the interventional cardiologists could not be blinded, and the study was fully funded by the Spanish Society of Cardiology. We wanted to have a representative trial from the clinical practice. So we designed a trial with an all-comers design within the diabetic population. So no restrictions were put in the clinical presentation of the patient or the complexity of the lesions. So interventional cardiologists were allowed to randomize patients with left main disease, multivessel disease, bifurcations of two-stent technique, chronic total occlusion, ST segment elevation myocardial infarction. All of these patients will be included in the SAGAR trial, with the only condition to have diabetes mellitus according to the American Diabetes Association. As I said, patients were randomized to Cre8 stent, which is this stent that is polymer-free. And because it's polymer-free and only 7 to 80 microns strut thickness, the total device thickness is 70 to 80 microns. No polymer causing permanent inflammation, and the drug is released with a carrier. The other patients were randomized to the Resolute Onyx stent that, as you may know, the total device thickness, including strut and polymer, is 20 to 30% thicker. The polymer is permanent, and the drug release is thotarolimus, which is released by simple diffusion. The primary endpoint was the combine of cardiac death, target vessel MI, and target lesion failure at 1 year. All the events were adjudicated by independent clinical event committee, facilitated by a core lab. And the hypothesis at 1 year was non-inferiority, but a Prespecified superiority was specified in case that the non-inferiority was met. As I said, 1,175 patients were enrolled, half randomized to Cre8 and half to Resolute Onyx stents. There were no patients withdrawing consent, and very few patients were lost to follow-up. So more than 98% of the patients were followed up to 1 year. In the baseline characteristics, as you can see in this slide, there was nearly 50% of acute coronary syndromes, with 12% of ST segment elevation myocardial infarction. Most patients randomized had type 2 diabetes mellitus, and nearly 40% of the patients, 40 to 50% of the patients, had multivessel disease. Also, most have the syntax score at the lowest tertile, probably fitting to the current practice of the current guidelines of myocardial revascularization. There were 3 to 4% of patients with target vessel being the left main, chronic total occlusions, bifurcations with two stents technique, and also rotational atherectomy. Regarding the drugs, 20% of the patients received the drugs that Daniel brilliantly stated in their presentation that modify the prognosis of diabetes. And the rate of DAPT at 1 month was comparable for both groups, and also at 6 months. But as you can see in the lowest part of the slide, more patients in the Resolute Onyx group received DAPT at 1 year than in the Cre8 EVO group. Regarding the primary endpoint, the rate of target lesion failure at 1 year was 72% for Cre8 EVO and 10.9% in patients receiving Resolute Onyx, which met the non-inferiority criteria and also the superiority criteria, reducing by 35% the risk of an adverse event in the target lesion failure. Regarding the components of the primary endpoint, the cardiac death on the top right part of the slide was comparable in both groups. There were slightly less target vessel MI in the Cre8 EVO group, defined according to the third universal definition. When we look to the ARC2 criteria, this difference was nearly significant, was a trend with a p-value close to 0.08. And also there was a significant, important trend to reduce the TLR in the Cre8 EVO group. As you can see here, there is a bump in the in target lesion revascularizations in the Resolute Onyx group, because I think this is the point when patients start to become symptomatic and then came to the cath lab. In the subgroup analysis, we saw that the treatment effect was consistent across all the pre-specified subgroups. And regarding other secondary endpoints, we saw that the rate of definite stent thrombosis at 1 year was comparable in both groups. It was close to 1%. And the rate of target vessel failure was also significantly reduced in the Cre8 EVO group by 33% risk reduction. The major adverse cardiovascular event, there was also an important numerical trend to be reduced in the Cre8 EVO group. So to conclude, dear colleagues, SUGAR is the first power trial to compare new generation drug-eluting stents in patients with diabetes mellitus. There was no previous trial comparing new generation DES in this population. And this is also the first ever to include a broad population, because the few trials that we have previously, such as the Tuxedo trial or the Reservoir trial, they have very, very restrictive criteria. So this is the first to compare new generation DS, and also the first to have an all-comer design. And the conclusion of our trial is that Cre8 EVO stents are superior to Resolutonic stents in patients with diabetes, reducing by 35% the risk of having a target lesion failure at 1 year. Of course, we'll continue to investigate on this topic. It is very important to have longer follow-up of our patients, because I think that we will have a lot of target lesion events from year 1 to 2 years, and especially after 2 years, we will have a lot of events out in another lesions in another vessels. It is very important also to investigate the role of SGLT2 inhibitors, to role of a tight metabolic control in outcomes in our patients with diabetes. We will also look to the outcomes of our patients with multi-vessel disease, and we would like to compare them with other historical cohorts. And of course, we are also working in the design of the SUGAR2 trial and anything else that might help to improve outcomes of this disease. For more details, you have the entire paper in the European Heart Journal. Thank you for the invitation to Alvimedica, and thank you for the nice presentations to my colleagues.
Thank you, Rafael. Thank you, Daniel, for your presentation, and thank you, Rafael, for your terrific results. They are very impressive in a field that is always more challenging for us. I would invite all the audience, if you active your video, Rafael and Daniel, I invite all the audience to raise the hand to start the discussion. We have about 25 minutes for discuss these two speeches, for discuss about the latest results about Cre8 EVO that were presented at TCT. Waiting for some question from the audience. I have just the first question for your results. We know that several years ago, or from several years, all the main topic has been the safety of the drug-eluting stent, despite the efficacy. About 10 years ago, we care only about the efficacy. Now, in the last years, we take care about the safety, bleeding, not bleeding, bleeding patients, frail patients, etc. We know that about 50% of patients have start with the bleeding risk, and the bleeding rate increase after 1 month after the stent implantation. You show these results in diabetic population that I would remind to our colleagues that the diabetic patient, it's a little bit in the gray zone between ischemic and bleeding risk, because he is a patient with high ischemic risk and high bleeding risk. For this reason, this trial showed us the incredible result in terms of efficacy. But do you think that when a stent is efficient, so as the Cre8 EVO stent, it could be also safe for the bleeding risk? I mean, we know that bleeding and ischemic risk are very interconnected. Between if you implant a stent that it's less efficient, maybe you have more ischemic result. I mean, you have more ischemic rate, and thus you have to make a re-PCI, and you have to restart with the double antiaggregation therapy after 1 month or after 6 months. And thus you increase the probability to have bleeding risk in this patient. Thus, I think that to have a stent that have a good answers for the bleeding risk patient, but incredible answers from the ischemic risk patient, in particular diabetic, I think that it's the real tool that is in the middle of the problem. What do you think about this comment?
Thank you, Rino. Yes, I think that you give with the key. For these patients, we always care about efficacy, and we forget the importance of safety. So if the patient has it is proven that if the patient has a bleeding event, it has a very poor prognosis, even more than if it has an ischemic event. In our trial, we found that patients treated with Resolute Onyx stent have a higher rate of DAPT at 1 year compared with the Cre8 EVO stent. And I think that one of the reasons for this finding is that more patients in the Resolute Onyx group had ischemic events. So if they had a target vessel MI or a re-PCI, they need to restart the APT. So in this case, as you said, it is very important to link safety and efficacy for these patients. You cannot give a patient a stent that allows him to give 1 month APT, but then this stent has a restenosis. So 1 month APT, but then a re-PCI at 6 months, restart the APT probably with new antiplatelet drugs. And for this reason, I think that it's very important in patients with high bleeding risk to avoid restenosis and re-PCI.
Before to give the word to Daniel, we have a very interesting question to Rafael. Do you think another multi-center randomized control trial involving patients in USA, South America, and Asia is needed to confirm the sugar trial findings?
I think, thank you for the question. I think that our trial has proven that Cre8 is superior to Resolute Onyx stents. I think that what the audience is asking mostly is if our results are generalizable to other stents. And so if we can state that this stent is superior also to other stents. I think that we cannot test the Cre8 stent against any other available stent, but for what I know, I think that other initiatives are currently ongoing to test the Cre8 against other devices. From my perspective, I believe that in the scenario that we test the Cre8, we can state that it is superior with the power of our trial, but of course, we cannot generalize. I don't know if it will be superior for other devices with thinner device thickness and with other scenarios.
Please, Daniel, you have some comments or a question to Rafael?
Yes, thank you, Rino. So first of all, I would like to join you that I think that target vessel failure and instant restenosis is not a benign process in patients with diabetes. So I can recall many of my diabetic patients in whom I placed the DES, and we had restenosis, and the patient come back again and again for repeat PCIs, repeat intervention, ended up with bypass surgery. So instead of trying to solve the problem after restenosis is coming, I think it's very important to use the perfect device at the first moment, because if you fail in the upcoming repeated angios, you may not optimize your results with repeated PCIs and cabbage operation. So that's the reason I think it's very important to know about whether the patient has diabetes or not, and use the correct device to have the lowest rate of restenosis. And with this, I would like to ask Rafa that in your trial, you included patients who had known diabetes, but we in our practice know that in many patients, we don't know that is the patient diabetic or not. It turns out after PCI, the stent is already there. So with your results in your mind, would you recommend pre-screening the patients or just using the stent? In most of your cases, what is your solution?
Thank you, Daniel. I think that this is a very important question. I think that right now there are worldwide nearly 250 million patients with undiagnosed diabetes. So yes, we have a lot of patients that are at high risk of events were treated with DS that probably will need a dedicated stent, such as the Cre8 stent, and also these drugs that you described before to modify their prognosis. In our hospital, we are very strict with that. All patients that are admitted, they are testing during the admission for diabetes. But I know from other centers from Middle East and Asia also that have instant tests for glycated hemoglobin. I think that will be very important, what you said, to have this test in the lab, because probably the treatment should be completely different.
We have another. Oh, please, Daniel. Sorry,
No,
we have another question. No. Please, you can make your comment. Then we have another question from another friend from the audience. Please, Daniel.
I just wanted to reply that we also think that this is very important, and we also trying to launch some registry or study on this to find out how many of the coronary patients have undiagnosed diabetes, but also, you know, diabetes and pre-diabetes are very, very close to each other. So we may focus on these patients with more attention, because I think this will be the key to treat them appropriately. Thank you.
Okay, we have this question to Rafael. Hi, Dr. Rafael. Thank you for the excellent presentation. In the study design, 2,000 over patients were not screened or eligible. My question is, why many patients were not screened and included in the study?
Thank you for the question. We did not ask to the participating centers which was the reason, only the numbers. I think that many of these patients probably had multi-vessel disease. It was mandatory in our trial that all patients with multi-vessel disease, because they were diabetic, were presented in her teams. So probably some of these patients underwent surgery, because as you see in the presentation, most of our multi-vessel patients have a syntax score in the lower tertile. So answering to your question, I think that many patients underwent surgery, and probably other patients were treated in centers participating in another randomized trials, or just probably they were patients treated during the weekend or during the night. So we didn't ask the reasons, but I think that was the most important reasons. Surgery, of weekends or nights, and patients randomized to other trials probably.
What you talk about the surgery and making a glimpse in the future. What do you think about all the trial that were that compared DS and cabbage? Not were comprehensive of a dedicated desk.
Yes.
Maybe in this case we have a dedicated desk. What do you think about the trial between cabbage and Cre8 EVO?
For example, for FAME3, many criticism has been done for this trial. I think that if we are going to do another freedom trial, we need to use more intravascular imaging, better medical treatments. Of course, I think that probably Cre8 should be used in most cases. For the freedom trial, there was no recommendation about the type of DS, and most patients were treated with Cypher or Taxus. But in this case, I think that with intravascular imaging, better treatments, and Cre8 stent, probably we could close the gap for target lesion events. But the problem is that from year 2 to year 5, 80% of the events in diabetic patients occur in non-target lesions. So I think in these cases, in centers with large surgical experience and high numbers with arterial revascularizations, I think that we may face some problems to getting there.
Rafael on fire. 2 questions for Rafael. The sugar, but it was expected. The sugar trial showed post-dilatation of stents are rather low in both arms, about 25%. Nowadays, post-dilatation of DES is considered as almost mandatory. What this data captured properly?
Probably the POT is mandatory for bifurcation techniques and for left main disease. But for example, post-dilation is not recommended for ST segment elevation myocardial infarction PCIs, because it may increase the risk of no reflow. And you have to remember that 50% of our patients were acute coronary syndromes. 35% were non-ST segment elevation, and 12 or 13% were ST segment elevation. I think that for this reason, these acute coronary syndrome were probably not post-dilated. And in the other cases, I'm not sure which was the reason. I hope that most of the cases for left main or bifurcations receive post-dilation, but we haven't deep into that data.
Okay, we could get the last question, very 2 seconds, and then I make my conclusion. I thought it was up to 5, but it's up to 45. I'm sorry for that. What was the rate of imaging in the sugar trial?
Yes, this is linked to the previous question. I think that the rate was low, was very low. I think I remember that it was close to 6% of PCIs. It is included in the manuscript. I think in the appendix, supplementary appendix, it was 5 to 6%, which is supposed to be low. But when I saw this data before submitting to European Heart Journal, I looked to other trials, such as the Bionic trial or the Talent, which are published in Lancet, and the rates were very comparable. I don't know why, if patients with complex lesions are not included in trials, or patients with the most complex lesions were submitted to surgery, but only 5 to 6% of patients underwent intracoronary imaging guided PCI.
Okay, thank you, Rafael. Just to conclude this wonderful session, unfortunately, because it was very interesting, just 2 take-home message. The first one, and the last TCT, it was shown these results from BioResort, final 5 years data that shows that independently from the latest DES technology utilized, they compare resolute integrity, durable polymer, not durable polymer, etc. The PCI outcome in diabetes mellitus patient is worse than in non-diabetes mellitus patients. Thus, diabetes, it's an independent predictive factor of MACE, in particular TLF. And Rafael showed us these terrific results, Cre8 EVO stents versus Resolute tonics. This was the first power trial to compare second-generation drug-eluting stent in patients with diabetes, only patients with diabetes, and the first to show a meaningful reduction of events after the drug-eluting stent implantation in diabetes. Rafael showed the difference, that it was not non-inferiority but it was also a superiority of Cre8 EVO versus resolute tonics in diabetic population. Thus, I would to conclude before to thanks Rafael, Daniel, and Alvimedica, that someone said, I have a dream, we have a dream, and I think that after this trial, the sweetest dream has become reality. Thank you to the audience and to my friends and colleagues. Bye.
Bye-bye. Thank you, Rino, for the great
Bye-bye.
presentation.